All right, let's talk about Eptifibatide. Now, it might not be a household name, but this is a drug that's engineered to work right at the very heart of a life-or-death medical crisis.
So here's the big question, right? How do you actually stop a heart attack while it's happening? I mean, this is one of the most critical questions in all of medicine. When an artery to your heart gets blocked, every single second counts. And to really understand the solution, we've got to first understand the problem. Our body's clotting system it's amazing, really. When you get a cut, it jumps into action, stops the bleeding. It's a lifesaver. But what happens when that exact same system goes haywire inside a crucial artery? Well, it becomes a life-threatening betrayal. Okay, so picture this. Inside our arteries, these fatty deposits, what we call plaque, can start to build up over time. And if one of those plaques suddenly breaks open, the body freaks out. It sees an injury, and it sounds the alarm. This kicks off something called the final common pathway of platelet aggregation. Just think of platelets as the bloodstream's first responders, and suddenly they're all rushing to the scene of the accident at once. So, how does this whole traffic jam happen? Well, it's a cascade. First, you've got the injury, that plaque rupturing. Almost instantly, platelets get the signal, they're activated, becoming super sticky and ready to clump up. Then, this protein called fibrinogen comes in. It's like biological glue, or a bridge, that starts linking all those platelets together. And the final step? You get a thrombus. That's the blood clot. And if it gets big enough to completely block blood flow to the heart, well, that's a heart attack. Okay, so if the problem is all these platelets sticking together, how in the world do you stop it? You need something incredibly precise, a tool that can get in there and intervene at that exact moment. And that tool is Eptifibatide.
Yeah, Glycoprotein IIb IIIa inhibitor. That is a mouthful, I know. So let's just break it down. Glycoprotein IIb IIIa, let's call it GPB-B3A. That's just the scientific name for the receptor. Think of it as the docking station, right on the surface of every platelet. And Eptifibatide, it's an inhibitor. Its one and only job is to block that docking station.
And this is really the best way to visualize it. Imagine your platelets are like these big ships, and they're all trying to link up to form a massive, impenetrable blockade. The fibrinogen we talked about, that's the bridge that connects one ship to the next. So what does Eptifibatide do? It's like a custom-made lock that fits perfectly onto each ship's docking port. With the lock in place, the bridge just can't connect. It's such an elegant and brilliantly simple mechanism, really. And what's so important to understand is that it doesn't actually destroy the platelets or anything like that. It just physically stops them from linking up. This action is competitive. It's fighting with fibrinogen for that spot. And this is the really key part, it's reversible. That means when you stop giving the drug, the locks just come off and the platelets go back to their normal business.
All right, so we've got the how it works down. But now let's talk about the when and the where. Because you don't use a drug this powerful for just anything. It's saved for serious cardiac emergencies. You'll see it used in two main situations. First is what we call acute coronary syndromes. This is when a patient is having a really high-risk heart attack, or they're right on the edge of one. Eptifibatide comes in to basically stabilize things, to stop that clot from getting any worse before they can get to the cath lab for a procedure. The second scenario is during a procedure, like getting a stent. I mean, can you imagine you put this brand new stent in and a clot forms right on it? That would be a disaster. So Eptifibatide is used to make sure that doesn't happen.
But, and this is a big but, here's the tension at the heart of any really potent anti-clotting drug. Its greatest strength, that amazing ability to stop clots, is also its biggest risk.
And the logic here is pretty simple, right? If you have a drug that's powerful enough to stop a life-threatening clot from forming in a coronary artery, it's also going to stop the, necessary clots from forming elsewhere in your body. And that means the number one risk by a long shot is bleeding.
And this risk really runs the gamut. It can be something relatively minor, like some extra bruising where they put the IV in, or maybe some bleeding from your gums. But it can also be much more serious, like a major bleed in the GI tract. And then there's the most feared complication, the truly life-threatening one, an intracranial hemorrhage, which is bleeding inside the brain. This is exactly why using this drug is always a careful balancing act.
So what do you do if one of these serious bleeds happens? Well, the main move is pretty straightforward. You stop the infusion. That's it. There's no magic antidote, no reversal agent you can inject. You just have to stop the drug and let it wear off on its own.
And this is why that whole reversible thing we talked about earlier is so incredibly important.
Once you stop the infusion, platelet function starts to get back to near normal in about 4 to 8 hours. That relatively short half-life is a huge safety feature, and it was absolutely designed that way on purpose.
Now, besides bleeding, there are a couple of other things doctors have to watch out for. There's a rare but very serious condition called thrombocytopenia, which is a sudden, sharp drop in the number of platelets. And of course, there are strict rules about who can even get this drug in the first place. If you have active bleeding, or you just had major surgery, or have a history of a bleeding stroke, it's an absolute no-go. All of this just underlines why a patient on Eptifibatide has to be monitored constantly, usually in a critical care setting like a CCU.
So, okay, we know how it works, when it's used, and the risks. The big question now is, where does this powerful drug actually fit into a cardiologist's toolkit today? Because, like with everything in medicine, things evolve. And this is where the story gets really interesting. The routine, day-to-day use of Eptifibatide has actually gone down quite a bit. And you might be asking, why? Well, it's because the whole game has changed. We now have newer, really potent oral antiplatelet drugs that you can give to patients much, much earlier. So instead of being the first thing doctors reach for, Eptifibatide is now often kept in their back pocket, so to speak. It's reserved as a bailout therapy. What that means is, if a cardiologist is in the middle of a procedure, maybe putting in a stent, and they see a massive clot or the blood flow just isn't looking good, that's when they can grab this incredibly fast-acting IV drug to handle the crisis right then and there.
When you really think about it, the story of Eptifibatide is kind of the story of modern medicine in a nutshell. It's about this constant journey to create sharper and sharper tools to intervene in our body's incredibly complex systems. And it leaves us with a really important question to ponder. As our drugs get smarter and more precise, how do we master that delicate balance between helping and potentially harming these powerful systems we're trying to control?